So I'm Klaus Schmierer. I'm a professor of neurology at Queen Mary, University of London, and a consultant neurologist at Barts Health NHS Trust. And I work in the field of multiple sclerosis for more than 20 years now in basic and clinical research.
I'm Dominic Shadbolt. I've been told I'm an expert patient, but I run a YouTube channel about MS, patient to patient. But I'm also involved in clinical trials with Klaus at the Royal London, Assist, but it's, I've had MS 31 years, so it's a case of, I've just sort of gravitated into that.
The idea for this project is slightly manifold. So one aspect clearly I think is highly relevant is patients that need follow-up for their disease-modifying treatment, that MS needs to be treated effectively. And in order to ensure that efficacy, we need to use all tools available to ensure that. And the best and most sensitive tool currently in use is MRI, magnetic resonance imaging. Now, the problem with MRI and serial MRI is that once patients are diagnosed with multiple sclerosis, the follow-up can become quite complex because as the pathology visible on these scans evolves, it's more difficult, becomes more and more difficult to identify small changes that may be relevant for their overall outcome, but difficult to detect in just when you just eyeball the scans. Now, AI is obviously a buzzword for so many, or buzz term for so many initiatives and work streams now. But for us, it is a very focused approach of using a technology to essentially help the reading of these scans, help the radiologists reading these scans, making it A, more efficient, B, more accurate, and thereby enabling decision making based on that. Because what we do with changes that we see on scans is we make new decisions about treatment, and if they are missed because the eyeballing wasn't sort of sensitive enough, or the software, we're testing that in the study, then obviously you have wasted a scan, you've wasted maybe a year of treatment, and you've wasted a year of quality of life in the individual, most importantly, who may not be effectively treated. So this is it really in a nutshell, if you can call that a nutshell.
I take a different, complementary but different view, because I come from a technology background, albeit on the business side, but I look at this as a patient and I think essentially, doctors don't always want to hear this, it's broadly better, providing it's better trained, because AI is, people get confused. AI isn't about the algorithm. It's not about the software or the computing power or anything like that. It's about the algorithm. So in this instance, and there's more than one company, but in this instance, it's icobrain, who's a spin-out of the university in Belgium, and it's researchers looking, because it's not 2D, an MRI scan. It's lots of slices, and everybody looks at a lesion and thinks that it's actually a 3D lump, if you will, like that. And this can look at the way that's developing, and it can model it all together. So a human being has to look at one slice at a time, but the computer can then just assemble all of them in its head, look at them as a 3D object, roll them around in its head, see if it's changing in a certain direction. Frankly, its dog wasn't run down this morning, it's not sleep deprived, it doesn't need another coffee, it is like a robot, which every single time. So it's augmenting the human ability, because I think the real skills with doctors come when all this is done. Then you're talking to me or the other patient about this is what we've got. But that as a diagnostic tool is a vast difference in aid, and it will never pass a human being. You always need somebody to sort of essentially check it. But it's like self-driving cars. People like that are comfortable.
That's why we call it assist, right? It's not sort of take over MS. It's really an assisting tool. I think you made an important point that obviously that, and nobody would like to say that it gets a bit boring for radiologists to look at scans.
It must be dull.
But it is not about boring as such. It's really about the fatigue that kind of kicks in over time. Looking at scans, particularly those where there's more complexity, right? Where people have had the disease for some time, and therefore there's not only individual dots and lesions, but confluency and marginal change, which is important for the biology of the disease, but not so easy to recognize when you just do it by eyeballing.
But a person looking at one slide at a time, for want of a better thing, the computer just goes, dunk, takes all that, puts it into 3D, which is what we are, we're all 3D things, and it can sort of roll it around and think about it in a way that the best intentioned and the best trained and the most alert person can't hold all that information in their head from everything. And it's sort of emotionless in the sense it just goes, this is what I see, this is what's different. You know, and then it's up to the person.
You have a lot of trust in it. That's why I'm really of the view we need to test it in clinical practice and then know, hopefully, that it is indeed sort of doing what it says on the tin, that it does assist and not actually contribute as much as we hope it will. Obviously, I'm very hopeful it will succeed, but let's see. That's what the project.
Whoever thought of a company called Amazon selling books? I remember when they started, and you bought books in them now, Oh, I think I want a blender. Oh, I think I want a barbecue. You know, I mean, you know, the way technology just, you know, and I can have it tomorrow. And it's the whole. I don't think it'll prove to be wrong. I think you're right. We need to moderate it and manage it and everything. But it won't. We can't put the genie back in the bottle.
I think it is about the size or the scale at which we're trying to implement these things sometimes. And I think what is good about Assist is I think it's at the pitched at the right level, at the right size. One previous IT application, I remember, was to convert or use one IT system across the whole of the NHS, right?
Oh, wow.
Which was a great idea, but it completely failed, right?
I think somebody set fire to about £80 million in there.
That smaller units are, I think, the right way to go, and also not to expect too much of the software at the same time. So I think that's why I think Assist is really well pitched for hopeful success.
I think if we take all the sort of clinical huggy, touchy feeling out of it and just go, the NHS is incredibly stretched. All the people that work in it, thankfully I don't, but you know, if you're a neuroradiologist and you've got a parties and you deep down you want to do as good a job as possible, but it's really, really difficult and the load keeps building up. If this can help, if we can show that this can make it so that at least they can look at the AI scan and then add to that rather than have to go the other way around, that's going to be a huge benefit, because in the MDTs, when you're presented with something as the doctor and the nurses and the pharmacists, you can trust it.
Yeah, I mean the problem is exactly. I alluded a little bit to that the NHS is such a dire state that even the small extra investment into something that is likely to pay off significantly is often too much, right? So that is what we experience with the whole problem of embedding the technology required to actually just transfer scans. It's a whole list of committees, safety checks.
Boy, oh boy, I've sat in on all the meetings with you, just going, wow.
That need to go through. I think this is really a bit of a message for sort of the NHS leaders in the field, etc., to make sure that if you're supporting research of that type, the NIHR, you need to make sure that trusts really are completely lined up or aligned with that concept, that they help implementing it.
But it's a conundrum. We can never just say stop. We haven't got, it's, there's an opportunity cost to doing everything. So I think the challenge is that the cost isn't in harming patient care, or frankly, you and your colleagues just going, I cannot take any more. I'm going to Australia, or whatever it is, because you've got all these sort of different, almost non-clinical issues, competing. But it's a balance. But that's how progress works, essentially. And sometimes people get hurt in the course of progress, and I'm not advocating it, but that happens.
So AssistMS is a study testing the application of a software called icobrain MS from Icometrics, which is the company based in Leuven, Belgium. And we have won jointly a grant from the NIHR AAC, or Accelerated Access Collaborative of the NIHR, to test this in clinical practice, because this is what really been defined as a desirable study based on a technology, a nice technology assessment. So what it does is essentially helping to assess the volume of lesions and the whole brain on using MRI brain data sets. The study is going to be conducted at 3 sites across the UK, so it's the Royal London Hospital, Birmingham and Nottingham. We will recruit just over 1,300 people with MS who do not have to have extra MRI scans. We will simply use their data sets and then randomize them into those who are being assessed by the radiologist with or without the tool. And then we'll look at what's the difference in terms of disease activity detected, and then the decisions that are being followed as a result of that. We'll also look at smaller elements like how long does it take for the radiologist to assess the scans with and without the tool. We will have a gold star team that gets all the information and then makes essentially a top judgment about it. We will also test it in radiologists who have no special training in multiple sclerosis, even neurology, to see how much essentially added benefit or how quickly they can be trained up to use this for the benefit of reading these scans. So it's a 3-year project. We are currently completing the protocol, then submissions to the ethics committee. Everybody obviously needs to consent to participate in the study, and we'll hopefully have first results of this in 2027.
Hey, I think we're having this discussion. Is it going to be a problem to recruit patients? Let me see. Would you like the computer to look at your scan as well? Yes, please. It's a no-brainer. The thing is, I think the problem you'll have is people going, can you make sure that mine is looked at? It's like, well, it's randomized, I'm afraid. So it's, but also Klaus touched on something, expanding out the capability to the more general radiology world. So we were talking about resources and everything like that. So as opposed to needing a specialized neuroradiologist to look at these scans, if this software turns out to be as good as, frankly, I expect it to be, but I'm biased because I haven't got all the clinical baggage on my, but then can you just imagine, wham, you do it through it, the radiologist checks it, is there any inconsistencies, does everything make sense, and then, especially when you look at areas, there's parts of the UK that in terms of MS, might be slight sort of neurological deserts, or I'm not sure what the right term is.
Hinterland.
The hinterlands, yes, much better, yeah, good German word. And it's, but if the radiologist there, where it's not a specialist MS center, can also be applying they can get the same quality that you could do in, say, the Royal London or Nottingham or Birmingham. How amazing is that for patients? So you're not thinking as a patient, geez, to get the best care, I really need to be one of these, when actually my local hospital is not an MS center, but they've got icobrain software or whatever it is, and you're pushing on an open door, I think.